I think we can get started. Welcome, everybody. Very excited to moderate a session on assessing myotomy during POEM. We have two distinguished speakers, two surgeons who have quite a bit of experience with POEM, as well as the workup for achalasia and other motor disorders, and also quite a bit of experience with impedance planimetry that can be used during myotomies like POEM. So we're very excited to have everyone. We're going to start with Dr. Andrew Sean Kastenmeier. We have a few slides that I have to go through, some disclosures here. This activity is designed for advanced learners and experts with at least a third of their clinical and/or research activities in foregut surgery. The learning objectives include discussing instances where a myotomy might be tailored to a specific patient, identifying the best, can you go back? Identifying the best methods and techniques for evaluating the adequacy and completeness of POEM. Can you go back a slide? Thanks. Describing key indicators and criteria used to determine the success of myotomy procedure, exploring advanced imaging modalities and intraoperative tools like impedance planimetry that can assist in assessing the completeness of myotomy, and discussing the workup and treatment of dysphagia. The provider verifies that sound education, principles have been demonstrated in the development of this educational offering. This is CME, we do not endorse or support the actual opinions of the speakers. Okay, next slide. You can see everyone's disclosures here. So again, this is CME for both physicians, nurses, other healthcare professionals. After the program, attendees will receive an email from the American Foregut Society with instructions on how to claim your credits. And this is a live activity. It's a maximum of 1 AMA Category 1 credit. Okay, so with that, we're going to start with Dr. Kastenmeier, who graduated from University of Wisconsin in Madison and then went on to medical school at the same institution, University of Wisconsin. He then completed his residency at University of Utah and then performed a MIS minimally invasive surgery fellowship with Dr. Lee Swanstrom and Dr. Christy Dunst in Legacy Health in Portland, Oregon. He then went on to his one and only job at the Medical College of Wisconsin, where he's associate professor. He's chief of the Division of Education, and he's program director for what I think is one of the best fellowships in the country in advanced GI, MIS, and bariatric surgery. His clinical practice is foregut, hernia, abdominal wall reconstruction, endoscopy, and endoscopic surgery. And he's going to give us a primer on impedance planimetry. Andrew, thank you again for agreeing to do this. We look forward to hearing your talk.
Great, thanks, Mike. Appreciate being here. Thanks for the intro. So our task today is to talk about assessing the myotomy during POEM. And in the past, we've had, when we're doing Hellers and when we just started doing POEMs, we only had a few ways of doing that, and most of them had some inadequacies with it. So, subjectively, we would look at on an endoscopic appearance of the EGJ opening, and you'd start the case, it'd be a pinhole. You do your myotomy, and you want to see that release and see that it opens. We'd measure myotomy length, which I still do. It's not terribly accurate, but it gives you a starting and ending point. You can measure the distance based off of the endoscope. People have described a 2-scope technique where you have a pediatric scope in the tunnel so that you can see how far the light goes down. You get a regular scope in the stomach, and you can see if that tunnel has made it past the GE junction. And then people have used dye as well. Other indicators that we've got are endoscopic appearance when you're in the tunnel. There's some characteristics of the gastric muscle as well that can clue you in that you're in the right spot. But in the end, these are what we want to know is if we got a good release of the valve, if we got a good release of the LES, and um, measuring the length of our myotomy is a surrogate for that. And then the visual appearance is really pretty subjective. So is there another way? And that's what we'll start to talk about today. So impedance planimetry is a way that we can actually measure how that valve, how that LES opens. And what impedance planimetry does is it uses electrical resistance, measured electrical resistance, to then determine cross-sectional area of a lumen. And there's a variety of different awesome physics formulas. And that over the next 2 hours, I'm going to go over each one of these in detail. Just kidding. We're not going to do that today. We'll do the busy surgeons primer on this, which is one slide. So in order to understand impedance planimetry, how it works, I think we have to understand the tool that we use to measure it. And then we can talk about both at the same time. So FLIP is functional lumen imaging probe. And the commercially available version of this is EndoFlip. But it's a device which usually utilizes impedance planimetry to determine the geometry of a lumen. And the FLIP catheter has 17 electrodes along it, each separated by a 0.5 millimeter in the small balloon, which is the 8 centimeter balloon. And then in the distal catheter, that whole area is housed within a compliant balloon that can be filled with a saline solution. And then there's a solid state pressure transducer at the end, which can also measure pressure. So how do we do impedance planimetry? Well, the balloon is placed across or within a lumen, usually across the GE junction. And then the bag is then filled with a conductive fluid. An electrical current is applied, and then voltage is measured across each electrode that's next to each other. And using Ohm's law, you can then calculate resistance, and from that you can determine what the cross-sectional area at that particular probe is. So it's basically using some physics principles to try and determine the cross-sectional area. So once you've got the cross-sectional area, that allows for additional calculations like distensibility and compliance that you can measure using pressure as well. And then you can get real-time measurements and can have those converted into a graphical representation, which we'll talk about what those look like in a little bit. So Zach's going to talk about how we use these numbers. I'm just going to get into what these numbers are and how they're calculated so you understand where we're coming from with these. So what we're most interested in and what's been studied so far, mainly out of Mike's group, is cross-sectional area. So that we get directly from a calculation based off of the resistance. From that, we can calculate what the minimum diameter is. And then when we also measure pressure within that bag, we can get a distensibility index. And that's going to be your cross-sectional area divided by the pressure within the bag. And that's really how does that area open? What's the opening like? Is it stiff or is it pretty compliant? And then the last is compliance, which is going to be your volume over the narrowest 2 centimeters of length divided by the pressure. And so it looks like it's pretty reflective of distensibility index, but it values the volume over the pressure just a little bit, to a cubed metric versus a squared metric. So it does give a little bit different piece of information than distensibility index. So when we actually do this in the operating room, how does that look? So first you got to zero the catheter. to atmospheric pressure. Um, we insert it transorally during the operation, and then advance the balloon until it crosses the GE junction. And I mean, I always do this under endoscopic guidance. Um, I'll have the endoscope in there, then I drop the flip catheter in, and then watch it go down across the GE junction. You inflate the balloon to a relatively small volume, 30 mils, and then you can adjust the position based off of what you're seeing on your screen. And recommended to have about 2/3, 1/3, meaning 2/3 above and 1/3 below, or you can go by the number of sensors. Then, for a one-time measurement, you inflate to 40 mils. You give it a good 30 to 60 seconds before obtaining your measurements. And from there, you can get your measurements that you're interested in. Now, the the measurements will be swinging up and down within a range. And so, you know, you're always asking yourself which of these is the right one, especially if it seems to be swinging at a relatively larger uh, rate. So there's filters on here, and the filter really averages out moment to moment variations due to manipulation of the catheter or any contractions or things like that. And if you put it on high filter, it just filters out that noise and averages out these static numbers over a period of time. And a high filter, I think, it's like 30 to 40 seconds where it'll average it out. And then you can get your cross-sectional area, your minimum diameter, your distensibility, your compliance, and then the intrabag pressure as well. And again, Zach's gonna get into what those numbers mean and how we'll actually use them during a case to assess the adequacy of the myotomy. Now, I think we should also just touch on using impedance planimetry to assess esophageal contraction patterns. So this is just a step beyond using it as an intraoperative tool to assess your myotomy. And what this is called is panometry. So basically you're distending a large balloon within the esophagus, and then you're evaluating distension-induced contraction patterns or secondary contractions. So sustained esophageal distension with one of these balloons induces a unique contraction pattern. And these are different patterns than the voluntary swallows that you get when you do high-resolution esophageal manometry. So a different assessment, but it gives you some unique information. These are just a couple samples of what some of those patterns might look like. It also still allows you to do characterization of the esophagogastric junction distensibility as well at the same time. So this can be performed intraoperatively, or this can be something you do in the endoscopy lab with a patient sedated. It's better tolerated than transnasal manometry. It uses a 16-centimeter catheter. It has the same number of electrodes as the 8-centimeter, but they're spaced 1 centimeter apart. You're generally using higher distension volumes. You're up at 60, 70 mLs, and you fill in 10 ml increments. And then for this, you want the filter off. You want those moment-to-moment changes. You're looking at the contraction pattern over a period of time. So you want that filter off during this part of the procedure. So you can see here a longer catheter goes across the GE junction. Again, you're having maybe 2 or 3 of the probes below the GE junction and the rest up in the esophagus. And you inflate that balloon and you'll get a contraction pattern. And a few of those patterns, so repetitive antegrade contractions, this would be considered a normal esophageal distension response. And to get this, you have antegrade contractions, and then it has to meet the rule of 6. So what that means is it's not just enough to have antegrade contractions. They have to be at a rate and consistency that meets criteria. So 6 consecutive, greater than 6 centimeters in axial length, and then it's 6 per minute, plus or minus 3 contractions. And so it's not just the nature of the contraction, but the rate of it and length of it that's important. And this would be a normal contraction pattern. Impaired, disordered contractile response, you see over here on the right. It's sporadic, it's disordered, it's incomplete, chaotic contractions. Absent contractile response, pretty self-explanatory there. You really have nothing going on. And then there's the spastic reactive contractile responses. So there's a couple different versions of this. You have a sustained LES contraction, which is an LES contraction lasting greater than 5 seconds, which you see just to the right of it. A sustained occluding contraction, which is a non-propagating contraction of both the body and the esophagogastric junction that persists for greater than 10 seconds. And then repetitive retrograde contractions are considered spastic reactive contractile response as well. And so you can see those contraction pattern there is going the wrong direction. It's retrograde. Now, depending on the pattern that you see, you can make some assessments about what type of disorder they have. And normal is pretty, if people meet that rule of 6s and they have antegrade contraction, that's they've got pretty normal motility. Now, if you fall into some of these other categories, some of them are a little difficult to tell exactly what the motility issue is, and you may need to move on to high resolution manometry, but there are some pretty slam dunk ones where you can diagnose achalasia. Not all of them will fall into a slam dunk. You're really confident that it's achalasia. Some of them might be a little bit more difficult to tell, but you can see here, an absent contractility pattern with a really high distensibility index at the GE junction, similar to a type 1. A type 2 here with some pressurization is what you'd call it on high resolution, but there's some disordered contractions there, and then high distensibility index or a low distensibility index, and then retrograde contractions, which you would see in a type 3, or you might see some of those other spastic features that I showed before. And this is just the same as you'd compare a high resolution manometry on the top to a panometry on the bottom. And I was a little bit hesitant to show this slide because really they're not meant to look similar, even though they do on this, because you're measuring a different contraction pattern. You're measuring a distension induced secondary contraction, and that's very different than a voluntary esophageal contraction, primary contraction wave. But so they don't always look the same for both because you're measuring something different. But in this particular slide, it happens to show representations that fall into a similar category. So panometry, one of the ways to use this, it can be performed at initial endoscopy for dysphagia or other issues. And the panometry might allow you to forego high resolution. If it's a normal contraction pattern, that's pretty indicative. It's, their high resolution manometry is going to be normal. The other is that you might have a really clear-cut contraction pattern that fits with a diagnosis, and so you may be able to be done after getting panometry and be able to avoid high resolution. The other spot for this is it can augment findings from high resolution manometry. So secondary peristalsis is not really assessed in high resolution, but is associated with different types of pathology. And high resolution still has some gaps where it's just not clear what the diagnosis is, and you need some extra information, and that's where panometry can help you. And then there's patients who you just can't tolerate manometry for different reasons. And so that's another spot where this can be used. All right. I'm going to stop share. We're going to have Dr. Ujiki introduce Dr. Callahan while he's getting his slides up.
Yeah, that was great, Andrew. Before we do that, I want to point out a couple things. Number one, please use the question and answer tab and feel free to send any questions. I'll be monitoring that, and I will, if appropriate, interrupt the speakers and see if they can answer. Otherwise, I may wait till the end and we can have a question and answer at the end as well. For right now, I would ask the audience if you have a chance to answer this poll. We've got a couple questions for you. With type 1 or 2 achalasia, how long typically is your myotomy if you're doing a poem? The options are 3, 4, 5, 6, 7 centimeters. So if you have an opportunity, please, let's see what people say here. Looks like the majority are putting 5 centimeters here. And one more question. And that has to do with type 3 achalasia. How long is your myotomy when you are treating a patient with type 3 achalasia with a poem? 3, 4, 5, 6, 7 centimeters. Yeah, the majority are doing long myotomies. So excellent. Okay. Well, I'm very pleased to introduce Dr. Zach Callahan, a good person, a good friend, and a good surgeon. He graduated from Thomas Jefferson University for his residency and then went on to do fellowship at North Shore University in Chicago. He's now the assistant professor for University of Tennessee at the Nashville campus, and he's got over 30 publications, 200 citations, active member of multiple societies, and has quite a bit of experience with both endoluminal surgery as well as impedance planimetry. So we're happy to hear from you, Zach. Thanks.
Yeah, thanks. I thought that the type 3 achalasia response was interesting. We'll have to kind of get into that, I think, more in the question and answer. I have no disclosures. Oh, except so I'm going to try and say impedance planimetry as much as possible, but I guarantee I'm going to slip a few endoflips in there, so I apologize just in advance there. So my goal is to help those that are incorporating impedance planimetry into their poem practice kind of have an evidence-based concrete number to shoot for. And I think when poem came out, we were no longer limited by surgical exposure. So these early adopters, I think they were happily opening the muscles as much as possible. We're doing full thickness myotomies, extending myotomies, very long lengths. And I have to admit, as someone who, my favorite case in the world is to do a poem. And when you do an aggressive myotomy, yeah, it's a little fun. And when patients come back in clinic and they're, so thrilled to be able to eat again, I think there's a lot of pressure to kind of try and open the GE junction as much as possible. But we know that post-poem GERD is a major problem. And this is a review that we did looking at rates of GERD after poem. And this is looking at symptoms. And, the larger sample size, you can see the rate, 16 to 22%. That's high, but certainly not horribly alarming. But the story gets a lot more alarming when we look at studies that actually have post-poem objective testing. And in these studies with people after poem undergoing pH testing, we see that rate much higher in the 15 to 88% range. I think what's even more concerning than that is just the fact that, clearly, if we're looking at symptomatic GERD rates, that is drastically underestimating the actual incidence of post-poem GERD. And I think this is why we really have to get this right. Poem is a great procedure. We know it works. We know it's safe. But is there a way to take this procedure to the next level? How can we tailor our myotomy so that patients have resolution of dysphagia, but decrease the alarming incidence of post-poem GERD? And I think impedance planimetry might be the solution to the Goldilocks dilemma. I believe this tool can help us tailor poems so patients have adequate resolution of dysphagia while minimizing post-procedure GERD. And before we get too far into it, I need to point out that although endoflip is a solution, it's not a perfect solution. There's a significant amount of data out there, but the data is flawed because there's no official protocol on how measurement should be taken. There's 2 catheter types, there's 5 balloon fills, there's multiple different disorders that we do poem for, both with all with vastly different prognoses. Certainly doing a poem on someone with a new diagnosis versus someone that's had achalasia for 50 years and they have an esophagus that looks like a sideways football, those people are going to have a different outcome. And also there's all these different metrics to look at, not to mention other factors, paralysis, holding respirations. And I think all we can do is keep publishing data and keep getting data out there and compare that data. Now, this is a consensus study. So these are expert people that do a lot of myotomies and have a lot of experience with the planimetry. And they basically came together to form a consensus. And they kind of recommending a shorter catheter, 40 milliliter fill, acclimating for 30 seconds. And this is a huge step in the right direction. But it's unclear, is this going to be adopted? Has it been adopted? And we just kind of have to wait and see on that. So with that grain of salt stuck in everybody's throat, let's look at the studies that have, they try and use EndoFlip to solve the Goldilocks problem. So this is the earliest study. It was done at Northwestern looking at EndoFlip measurements and outcomes. They had 36 POEM patients that had EndoFlip data, Eckhart scores, and they used the GERD-Q data. So they showed that after POEM, all patients had a DI greater than 3, and the entire population had significant drop in Eckhart score. And to help determine, how open is too open, they split the cohort into thirds and looked at patients with a GERD-Q score greater than 7, finding that none of the patients with a DI less than 6 had positive GERD scores. Then they did a sensitivity analysis to look at patients with an Eckhart less than 1, but a GERD-Q less than 7. And what they found was that 88% of patients with a DI between 4.5 and 8.5 had optimal symptom outcome, meaning they had resolution of dysphagia without a positive GERD-Q scoring. So obviously this study is horribly limited by sample size. Also, I just want to point out that a DI of 4.5 to 8.5 is quite a large range. Kind of hard to imagine, you're doing a POEM and you have a DI of 4.5. Hard to imagine you'd want to keep dividing muscle and maybe pericardium before getting up to 8.5. But this was kind of the first study that looked at that. So 3 years later, this is a group out of Hopkins. And this was a big deal because this was the first time that they actually had post-POEM pH testing as well as EndoFlip data. So they reported the expected decrease in both Eckhart and manometric IRP. But when we get into the EndoFlip data, things get pretty interesting. So the authors did the same thing. They split the cohort into good responders of dysphagia and non-responders. And you can see they found a very small, but still statistically significant difference between DMIN and CSA in the responders and non-responders. And interestingly, they saw no difference in distensibility index. And that's just the 30 milliliter fill. When they actually did the 40 milliliter fill, they were unable to find any differences at all. They do some fancy statistics and they come up determining that basically a CSA greater than 80, certainly a post-procedure CSA greater than 80 will give good resolution of dysphagia. And then they had 48 patients that had endoscopy or pH testing. And the authors, again, split the cohort into groups. So people that had reflux and those that didn't have reflux. And again, you can see a very minor but statistically significant difference in DMIN and CSA, but again, no difference in DI. And I just want to point out that, if you're looking at CA, the sweet spot is pretty narrow and quite hard to hit. And I'll point out, this was a multi-center study, so I can only imagine the differences in protocol and how these things were reported and how that may affect those results. So in Chicago, we used a prospectively maintained database, and we looked at 77 myotomy patients. 70 of these were POEMs. We also used that postoperative Eckhart score greater than 3 to indicate treatment failure. And then we split the cohort into responders and non-responders, and all EndoFlip variables we were analyzed, and we found that patients with a final DI less than 3.1 or a change in DI less than 3 were more likely to report an Eckhart score of 3 or greater, meaning more likely to basically fail myotomy. And saying this a different way and only violating a few statistical laws, basically a change in 3 or a DI greater than 3 is likely to result dysphagia. And then we used a slightly different reflux scoring system called the RSI, or Reflux Symptom Index. And what we found was that with a CSA less than 96, seemed to indicate that people would not have symptomatic post-POEM GERD. Same group, a few years later, but these patients had subsequently undergone post-POEM endoscopy, typically at 1 year. And this was kind of the major finding of that paper. Basically, that patients with a DI greater than 2.7 or a CSA greater than 83 were more likely to have esophagitis on follow-up endoscopy. And this CSA finding, it seems consistent with the Hopkins group and the prior study, but it creates a bit of a problem in terms of DI because we just learned a second ago that, excuse me, a DI greater than 3.1 demonstrates an adequate myotomy, and here we are asking for a DI less than 2.7 to avoid GERD. Symptomatic GERD was also looked at, and it just kind of reflects this idea of achalasia patients probably having silent reflux because there's no correlation between GERD scoring and their endoflip findings. This is one more study. This is out of the UK. It's a little more recent. 65 patients had flip data. They also split the group into responders and non-responders based on Eckhart score. This is obviously a big table and a lot to take in, but the big stuff is that patients that responded well had a median DI of 4 compared to 2.9 in non-responders, and then a change in DI closer to 3 compared to 1.5 in non-responders. And sadly, none of these findings reached statistical significance, and there was really no GERD data to report. I tried to stay out of the abstracts, but there's really pretty limited data. And I think this study out of Kaiser Permanente nicely kind of shows the pendulum swinging back the other way. So the authors found a 90 and a 93% success rate at early and later follow-up with an intraoperative DI of just 1.3, or rather intraoperative change in DI of just 1.3. And this is obviously a huge difference from the Teitelbaum-Su or Knight study there. So let's put it all together. So this is what we got. To resolve dysphagia, we need a DI somewhere between 3 and 4.5, a final DI, and with a change somewhere between 1 and 3. But if the DI is much higher than that, that patient is likely going to suffer from GERD. In terms of CSA, the sweet spot seems to be between 80, but no more than 100. So these are just my 2 cents and purely my opinion. I think distensibility index is going to be the powerful metric to look at moving forward. Diameter and CSA, these are measuring distances, but the esophagus is an extremely complex organ, and certainly the GE junction is even more complex. So I think, using a metric that's only looking at distance is not going to be sensitive enough. I think we need something that incorporates not only distance, but also pressure, and that's where distensibility index is so powerful. Along similar reasoning, I think a change in DI is going to be more powerful than what, it should the final absolute number be. Again, every patient has a different esophagus, a different GE junction. I think it just makes more intuitive sense to look at, okay, what DI are they starting out at? And then, how much change can we expect for them to have a certain outcome? And then I do want to point out, I think, when you review this data, it can be a little bit discouraging. You see a lot of different studies overlap, or, one study saying, okay, this is the number you need to resolve your dysphagia, but, that same number is the number that's going to give you a postoperative GERD. And it's important to point out that achalasia is a chronic condition. It's a complex condition. And for some patients, it may just require opening that GE junction. The amount that is required to resolve the dysphagia is the same amount that's going to give them GERD. And, a poem is a great tool, but it's just a tool, and it's certainly not a cure for achalasia. And some patients just, may develop GERD afterwards. And then I thought, now that I've kind of killed everybody with all the data, it might be fun just to kind of watch a poem. And this is from my fellowship, so I'll just kind of throw in a few pointers. So I always like to endoflip. Looks like we're lagging a little bit, but I always like to endoflip before pushing the endoscope down. I think the endoscope will kind of dilate up those numbers, and that distensibility might be artificially higher than it should be. So I always put the endoflip catheter down first. And then next what I do is I like to spray a lot of the methylene blue and try and figure out, okay, where exactly is 6 o'clock? I like to do my submucosal tunneler at the 3 o'clock position. I like the the angle at the bottom of the lesser curve is a lot less acute, certainly, than at the greater curve. So I think there's less chance of making a full thickness mucosotomy at the end there. And this is kind of a fine point that I think I didn't realize starting out, but once you kind of see your hole, it's tempting just to jump in and start creating your tunnel. But I think it's important to kind of spend some time clearing the submucosa around where your mucosotomy is. And what that's going to do is it's going to relieve tension so that when you go to close the incision you made, it's an easier incision to close. So you can see us kind of working down here, and a little counterintuitive, but remember that making a hole in the muscle on the right side of the screen is no big deal. You're going to do a myotomy on that side anyways. Even though the pericardium lives over there, it's no big deal. What you really need to avoid is making a hole on the mucosa side, because that's a full thickness hole, and we call that a perforation. And then once you're in your tunnel, you kind of get into, and this is a nice still shot just showing your mucosa off to the left and the muscle off to the right. And once you get going, you kind of get into a bit of a cycle where you kind of advance the scope, inject, and then buzz that submucosa. And then, you can kind of start to get a sense of, okay, well, maybe I'm getting close down to the GE junction. And again, I think I'm lagging a little bit, and there's a few hints. So one is that things get really tight down in the GE junction. And then 2, you start to see bigger vessels. And then the way that I check that is I like to flood my submucosal tunnel with the solution. And then we're going to pull out. And we're going to look, and you can see that nice blue tunnel going all the way down through the GE junction. And I like to go in, and then I like to retroflex and look up and really prove that I actually have a few centimeters down onto the stomach. You can see a nice like 2 to 3 centimeter extension there. And Dr. Kastemeyer did mention some other ways like the double endoscope method, which I think makes sense as well. Then it's time for your myotomy. So lately I've been aiming for about a 7 centimeter esophageal tunnel and then a 5 centimeter myotomy. And that's a great still shot showing you kind of the circular muscle fibers and the longitudinal muscle fibers off to the right. And I don't think there's any right or wrong way to do this. Certainly cutting the muscle from screen right to screen left is fine. It's kind of nice. You can see it kind of hooks that circular muscle up, kind of pushes the longitudinal muscle back. But the trick with this one is certainly if you're putting too much tension going that direction, you could accidentally overshoot it and burn your mucosal tunnel, or the protective mucosa of your submucosal tunnel. And then just to point out, it's not uncommon. You can see here, this is probably a little full thickness. And I've noticed that just tends to happen. The longitudinal fibers, certainly down closer to the GE junction, tend to get kind of thin. And it's not uncommon to see the heart or some lungs over there. And then you want to repeat your endoflip. Careful, don't do the endoflip blind. I have seen the endoflip go down the submucosal tunnel by accident, cause a full thickness perforation. So watch out for that. I like to clip close the mucosa. I like to go distal to proximal. I find that if you do this first clip well, a lot of times you can just get your cap underneath that, and that'll kind of tent things up. And I also think the most important clip is this one most proximally. I think that if you don't really have that hole well sealed, I think that's kind of where leaks happen. And you can usually get this done with 3 or 4 clips. All right, a few last points. So like we just talked about, flip first before your endoscopy so you don't dilate it up. You got to wait for the balloon to equilibrate. I think a lot of the early data is flawed because people are recording readings at low pressures. So I think the manufacturer wants between about 15 to 45 of pressure. I like it, certainly in the 20-30 range to make sure we're getting good readings. Check the pressure. Careful endoscopy. I've been sent a lot of patients for achalasia that don't have achalasia that end up having esophageal cancer or absent contractility. So always do a careful endoscopy. I think early out, I would make a mucosal tunnel, and then I'd think I went far enough, and I'd pop back out and check. And just you really want to be convinced you're beyond the GE junction, and flood your tunnel. Then try and only do it once, just for efficiency's sake. Certainly don't advance the endoflip blindly afterwards. And then I like the endoflip because when it balloons up, it kind of compresses that submucosal tunnel. So I like to then clip it closed after that. I try not to go back into my submucosal tunnel once I've endoflipped down, just because it kind of helps compress it. And then real quick, last slide, post-POEM dysphagia, what to do. I recommend a very high temperature shower cry. You just did this awesome poem and someone's come back into clinic and they can't eat again, but then you got to take a history. Is this the same symptoms, the same dysphagia that they had before? Does it feel any difference? Did they notice any difference after poem at all? I think it's important to get the op note. As surgeons, I think this is drilled into our minds in training, and certainly for my GI colleagues, it's always important to figure out, where was the poem done? Was it a 3 o'clock? Was it posterior? Was it anterior? How long of a tunnel was it? Did they do endoflip before and after? Get that information. Then you got to start the workup over. Get an esophagram, do another scope, do another manometry, do another endoflip. And then if things are still tight, yeah, you can do a repeat poem. You can just go in a different location than you did before. Certainly don't forget a surgical myotomy. Nothing wrong with that. Thank you so much for your time. I'll put this back up, and then I'll open up for question and answer and maybe some more polls. Thanks so much.
Yeah, Zach, that was fantastic. Both I want to thank both you and Andrew for outstanding presentations. I will open it up for questions. I have a few questions. I think one is, there are some surgeons out there who, and gastroenterologists for that matter, who may be in hospitals that don't have easy access to either manometry or flip. And if you had to choose one for your hospital right now, if you had money and your hospital approved you to buy one or the other, what would you buy and why? Andrew, why don't you start? We'll go senior to junior first, so the old guy can answer first.
Yeah, I'd say the best way to optimize outcomes is to make sure you got the right diagnosis. that's the priority. And for me right now, I can get the most patients accurately diagnosed with manometry. Um, I'd say I'd invest in high res. Now, I would also say that as we start to understand what panometry looks like for eosinophilic esophagitis and all these other diseases, it's going to get more and more accurate with being able to diagnose those. So I think it will replace because it's so much easier for the patient um, if we can get those more definitive diagnostic um, algorithms like we have for the Chicago classification. But I would say right now I'd still do esophageal manometry.
Yeah, Mike, I desperately want to say EndoFlip, but manometry makes me feel safe, and I think EndoFlip's a really sensitive test. It's really good at ruling out things. Um, but if you're not seeing the racks that Dr. Casimir is talking about, if things look kind of funky, I'm going to want manometry before intervening on that patient. But I don't know, Mike. What about you?
Yeah, well, I actually would, if I had my choice, it would be EndoFlip. And the reason is I think it's versatile. So we can use it in the operating room. We can use it in the GI lab. We can use it for diagnosis. But as you just showed, we can use it in the operating room while we're doing a procedure, or the GI lab while doing a procedure. And it gives us the information about whether or not we're done or not. I actually think as more data comes through, it's becoming clear that EndoFlip or impedance planimetry is very good at diagnosing problems with the LES, like it being too tight, whether it be EGJOO or achalasia. One where it may not be great, but neither is manometry, would be diagnosing things like GERD. I don't think it gives us information on necessarily a sphincter being too open or too loose. And so we can't use it to diagnose GERD, but neither can manometry, but it really is pretty accurate and consistent with diagnosing things like achalasia. So I actually would choose EndoFlip at this point, but we probably have used it more and feel more comfortable with it because I felt the same way that you all did. And it's interesting though, when you look at studies that have looked at and Dusty Carlson over at Northwestern did a good job of this. When you have a patient where you've done both manometry and EndoFlip, they actually agree most of the time. But in those patients where they don't agree, if you look at symptoms like, for example, dysphagia, and you look at time barium esophograms, they tend to agree more with EndoFlip than manometry. So I think we're fooled into thinking that manometry is always right. Manometry is the gold standard. And when they don't agree, EndoFlip must be wrong. But I actually wonder if that's true. And I actually now feel that it's possible that EndoFlip is more accurate in certain circumstances, especially when a valve is too tight. So that's my feeling.
There's definitely, Mike, there's definitely truth to that. I mean, um, the IRP is not the end all be all, right?
Right.
And an intermittent view of a peristaltic contraction. I mean, there's just little bits that can totally exclude a diagnosis of achalasia based off of manometry, and I'm not sure that's always the case. And so, um, I mean, that's why they're both important pieces right now,
Mhm.
because they both offer something that the other doesn't. But yeah, yeah, those are good points, Mike.
Yeah, I mean, I do think together when you have both, you're really taking comprehensive care of a patient with esophageal disease. So, um, and one thing Zach kind of mentioned what his myotomy length is. I think he said 5 centimeters, which actually agrees with the poll pretty well. Andrew, what length myotomy are you doing for type 1 and type 2 and type 3? And then Zach, you didn't talk about type 3 in terms of what you do.
Yeah, I do. I generally do a I start my tunnel 10 centimeters above the GE junction usually. So I'm doing about a 7 centimeter for type 1, type 2. So I do it fairly long still. Um, and then for type 3, I still do believe getting at some of that spastic segment. So I'll measure on the manometry, the high resolution manometry, the length of that spastic segment, and I kind of eyeball it from there. I don't like going the whole length, but I go longer for sure, than a type 1, type 2.
Yeah, I
Zach?
do a slightly shorter tunnel. So I do a 7 centimeter tunnel and then go 2 centimeters. So I end up with a 5 centimeter myotomy for type 1, 2, and then like 1 or 2 onto the stomach. And then type 3, I do the same. I do the same. I think it's tough. It'd be great to do like a selective myotomy based on your manometry. But what I've found is that, if you open up that lower esophageal sphincter well, even with type 3, patients will have a good improvement. I had a patient that her muscle, Mike, was like, it was the thickest I've ever seen. It was like I was cutting like roast beef or something. And I did just a 5 centimeter myotomy, and she came back and she was just, everything was gone. She was cured. So, and I think the concern is, Mike, I'm sure you're going to talk about this, but when you do those really long myotomies for type 3, it's great at the time, but then years go by and it just dilates out and dilates out. And, people have this just massive dilated, afunctional, soggy esophagus. And then they kind of need an esophagectomy.
Yeah, I agree. I think we were very excited early on with Poem back more than 10 years ago, and we thought we had the answer for type 3, which traditionally was the most difficult to get complete symptom resolution. But we couldn't really do a long myotomy surgically. Laparoscopically, it was difficult, and most people agreed that wasn't great to do it through the chest. So now we had an endoscopic way of doing a complete myotomy, but it did seem to work well in the short term. But in the long term, when people have complete loss of motility from a long myotomy, we do see people with kind of a big boggy esophagus that doesn't empty well, even despite the lower esophageal sphincter being open. So I personally feel, and what I will tell type 3 achalasia patients is that we're going to start with a short myotomy. I think we'll look at the manometry, see if there's some segments that we can target that are particularly spastic. And we can always come back and do more. We can always extend it longer. And I have done that on a few occasions where it was clear that the patient was having dysphagia, and on either a liquid or solid esophagram, you could see where things were getting hung up, and you could come more proximal if you needed to. So you don't really lose anything by doing a short myotomy. And fortunately, because it's an endoscopic procedure, going back is not that difficult. Now, one question I have for both of you that coming from the audience is, if you don't have endoflip, what is the best way to assess the adequacy of your myotomy during Poem? Andrew, why don't you start?
Yeah, I mean, we didn't have it before, so when I did Heller's, it was endoscopic. I'd do an endoscope and I'd look at sort of subjectively whether the GE junction was wide open, and then with the endoscope in there, then I would get an instrument and tap on the lower portion of the myotomy and see if, when I was looking with the endoscope in the stomach, if I could see that bottom spot. And so, it's the same deal now. Like Zach said, you can see some of that dye in the tunnel, and you want to see it on retroflexion. Um, I didn't do the, I don't do the double scope, but I think if I was stuck, then it'd be easy to drop um, uh, an extra scope in there and take a look that way. But I've never had to do that.
Zach,
Yeah, I think
how would
just
you assess?
yeah, I think you just kind of make sure you get all the circular muscle, if you're just seeing longitudinal, and then just make sure you're past the GE junction. And I think, if you do those two things, most of the times you'll get pretty close. I think it's rare that if you do that well, that things are still really, really tight. I think that's rare. I'm sure it happens, but it's rare.
And I want to hear a little bit about your post-op protocols for Poem patients. How are you getting routine esophagams? Number one, are you keeping them overnight or same-day surgery? Number two, How do you assess for GERD postoperatively? And are you treating people empirically or with antacids, or are you uh, just treating them with symptoms? Are you assessing people lastly with a pH study or anything at any time point? And if you are, when?
Let me start with that one, Zach. So I'll do either same day or a night in the hospital. I don't do a routine esophagram immediately after. Everyone, whether I do a POEM or a Heller, everyone goes home on a PPI. I actually start them on, I usually start them on double dose, and then after about 6 weeks, I drop them down to once a day, and they stay on that indefinitely. And then if they want to get off it, I'll do the pH testing at a year.
Yeah, I've been pretty lucky so far. So mine have all gone home same day, which is great. They go on, I do a Meprazole 20 daily for a year. And then at 1 year, I like to bring it back and do a Bravo. And then you just have a conversation of like, hey, you can just keep taking this versus, offer fundoplication at that time. Yeah.
So Zach, no routine esophagams.
No, yeah, no.
Excellent. And then another question is, what do you do? So you talked about EndoFlip, and maybe Zach will start with you on this one. But Andrew, I do want you to answer this as well. You're doing your myotomy, you're finished, you get the EndoFlip readings, and what if your distensibility index is still too low? What would you do at that point?
I'd reassess. I mean, I'd go back down, I'd go back in my tunnel and I'd see, did I really get all the circular fibers? And then I would consider extending the myotomy distally. I will say it hasn't happened to me yet. Pretty rare. But yeah, if I sometimes you get to a point where like you've divided every possible thing. Your myotomy is long, and and the other thing is when people start with a really really low DI, like they start with like a 0.2 or 0.3, like sometimes you'll only get them up to like 1.2, 1.5, but the kind of rule of thumb that we in fellowship was, either greater than 3 or 3 times what you started. And that I've never had to break that rule. I've always been able to get at least 3 times what we started. And those patients so far subjectively have done well.
Andrew?
Yeah, similar. I think this is probably the most common for me. This is the most common thing that happens because my initial approach is to go about 1.5 centimeters past the GE junction and to not do full thickness. And then I'll come out, I'll do an endo flip. And if it's too low, then my moves are extend it longer and or go full thickness in that GE junction area. Not for the whole myotomy. You don't need it up higher. But in that transition where you're getting into the, right onto the stomach, the fibers aren't always longitudinal and circular right at that point, right? You're getting a bunch of crisscross, whatever, and I say, damn it, we're just gonna take it all. And so I'll go full thickness down there. So those are the two moves, and I kind of base, which one do I do first? I mean, I guess I don't have a protocol for that piece. Sometimes I'm like, God, I've just been digging at this for a while. I guess I need to take it a little bit further. But sometimes you can tell there's still a hump there with those, with those, if you haven't gone full thickness yet, and you get through that. And I'd say that is usually the move that gives me the best release and the most reflux.
Yeah, that's a great point, and that's a good tip, actually. I agree with you. Let me ask you both, is POEM your primary treatment for achalasia? Do you consider a laparoscopic Heller myotomy ever? Or is POEM second to a laparoscopic Heller myotomy? How do you choose which one to do?
So I'll offer both. We discuss both. Um, and then I guess there's a couple of things. I think the insurance piece that used to force my hand. Didn't wouldn't be approved, a direct exclusion, all that sort of stuff. And so there were some hellers that I did because patients just they couldn't wait for the appeals, or we just lost the appeals. That's really gone away, at least in our area. Um, but there's the other where, they might have a hiatal hernia, um, or I mean, I am seeing so many more high BMI achalasia patients. Um, the standard patient profile that you read about in a textbook is gone. I mean, that cachectic patient, you know, that's not the standard at least anymore. And so um, sometimes when they've got um, you know, it's obesity as well. And we talk about doing an anti-reflux, like a bypass at the same time. I've done that as a POEM or a Heller at the same time.
You done a Heller combo bypass or a poem combo bypass? Wow. Mike, you done that?
Yes.
Wow, cool.
Yeah.
Yeah, I push poem pretty hard. So my practice is a little bit unique in that I'm the only person in my city that does third space endoscopy. So people usually come to me for poem. Um, I actually I know I kind of feel weird now that you said that. I don't even mention Heller because in my mind, like outpatient procedure, no incisions, barely any pain, like it's a no-brainer to me. But I guess I'm horribly biased actually.
No, I think there's nothing wrong with that. I mean, the way I look at it is that if if you do have, there's no question that GERD rates are higher after POEM than a laparoscopic Heller myotomy and partial fundoplication. No question. They're probably double. It's probably 20 and 40%. But the way I look at it is a outpatient fundoplasty is fine in a patient who is not willing to take a PPI if they do have GERD after a POEM. So you're talking about 60% of patients who are not going to have GERD that you just did a Heller myotomy, you just did surgery on, and a partial fundoplication who probably didn't need it. And so I think it's reasonable, and that's the conversation I have with patients that, if it were me and I was a patient, I would want a POEM. I'd want one of the two of you to do it. And if I got reflux, I would be okay with that. I would, either stay on a PPI or have you do a door fundoplication on me later. And but hopefully I wouldn't have reflux. And so I think there's nothing wrong with having POEM be first line.
Mike, do you do doors like for those interval fundos? Do you do a door like so say someone a year comes back, Bravo's positive. Do you prefer door to toupee or
I like door unless the patient has a hiatal hernia. So if the patient has a hiatal hernia that I missed in the original, pre-op workup, because if they do have a hiatal hernia, I do favor a laparoscopic Heller myotomy where I can fix the hiatal hernia and then if I'm doing any kind of mediastinal dissection, I'm going to do a toupee fundoplication. But if somebody comes back after a POEM and does not have a hiatal hernia, I will confirm the location of the GE junction at the time of the fundoplication. And if it is in the abdomen and I don't have to do much of a mediastinal dissection, then I will just do a door. And I feel like that's important because I think if you do a dissection that you don't need to do, you are risking a recurrent hiatal hernia later. And I will tell you, and I've had to deal with them, I'm sure you guys have, but dealing with a recurrent hiatal hernia in a patient with achalasia is a bit challenging because again, you want tight crural closure, but you really can't do that in a patient with absent motility. And so again, I think EndoFlip is ideal in that situation as well, because we know that we can close the crura a certain amount, but not too tight. But at the same time, it's just a little bit nerve wracking. So if I don't have to do a mediastinal dissection because the GE junction is actually located in the abdomen, I'm just going to do a door fundoplication and try to avoid doing any posterior dissection of the esophagus. So I think door is favorable. Last question, we're on the hour here, but you know, EndoFlip is relatively new technology. I think there's a lot of excitement around it. You guys both gave excellent presentations and talks on the benefit of it and how it works. Are there anything that you know now that you didn't know when you first started using it that you think might benefit an audience that's relatively naive to the equipment? So like any little tips and tricks, something that you kind of have figured out over time, like, oh, you know, this is important. I didn't realize it. Like Andrew mentioned the filter. You know, I think a lot of people don't realize how important the filter is. If you don't have the filter on and you're trying to measure the LES, well, every time the patient breathes, you're going to get different numbers. The numbers are going to vary a lot. So having that filter on is a big difference. Or Zach, you mentioned the pressure. Really, you need a pressure that's high. And that's very valid in poems because sometimes we open it up enough that the pressure goes really low. And I've seen very different numbers that are extremely inaccurate when the pressure is under 15. I would even argue under 20. You know, the pressure, the desensibility index starts to become a bit inaccurate. Are there any other pieces of advice that you would give using EndoFlip so that until we get more of a standard protocol, as you mentioned, Zach, people can start using it right away and feel confident in the information they're getting? Each of you just maybe one or two, and then we'll end there.
Mike, I think I mean, I don't want to repeat it but for me the biggest change was paying attention to the pressure because I was doing post myotomy 30 mil um 30 mil volume distension and getting just weird numbers and it wasn't consistent um and so I mean going with the 40 mil volume it was it's that higher pressure that helps you actually be able to get a more accurate distensibility index. And so um, that was a that was a really big change for me because those 30 mil volumes just weren't cutting it.
Yeah, I agree. I don't really have a real one, but I did sew one into the esophagus today. So just communicate with anesthesia, make sure that they pull it back when they say they're pulling it back. But look, I was able to identify the stitch. It was my last little stitch on the funda, so it worked out fine. But yeah, no, pressure's big. Yeah.
And I think that reminds me of any troubleshooting. So we just had this the other day. We finished a fundoplication, so it's not a poem, but we finished fundoplication, and we got our reading, and it was really didn't make sense. Our crural closure number looked good. And then we got our post fundoplication number and it looked worse, like too tight. And it just didn't really make a lot of sense. We pulled the catheter out, and sure enough, there were tiny little holes in the camera. I mean, in the balloon, possibly from our needle, because we do tend to leave it in there while we're doing the fundoplication. And just having that leakage of that solution out of the balloon really gave us inaccurate numbers. And I think it's very important for people to understand that. I worry that people sometimes will get inaccurate information. Either they put the catheter down, and as you mentioned, Zach, always do it under direct vision, because I have seen that catheter be pushed in and be kinked in the esophagus. And when it's kinked, you're going to be reading the kink. You're not reading the LES, and you could be very fooled into thinking that that's the LES. So I really think it's important as much as possible to place it under direct vision and make sure that it's sitting in the right spot. And then I think if you get numbers that don't make sense, troubleshoot it. You know, make sure it's in the right place. Make sure that your pressure, as Andrew mentioned, is at least 15, if not 20. Make sure that you have the right volume fill. And then if it still doesn't make sense, bring the balloon out and check it for leaks and make sure that it's working okay. And because I worry that, you know, people that are just starting to use it may just automatically assume that an inaccurate number is correct sometimes. And so you do have to use some judgment and make sure that you understand what numbers you would expect. And when you don't get that, troubleshoot the balloon.
I'd agree with that, Mike, and I'd take it even one step further, which is if it's still not making sense, after you troubleshoot, there's some stuff that you can't necessarily see that can go wrong with the catheter. So, like, you know, putting the catheter in through the bite block and you damage the pressure sensor, or it was out of the body while you were doing the operation, and you know, somebody dropped it on the floor and ran over the tip with a cart, you know, like, sounds crazy, but that's what happens, right? So
Or
if it
the
in the
cautery
end,
gets
if it all
hit.
doesn't, yeah, if it doesn't make sense, then I'll switch a catheter, and there's cost there, but that's that's worth it for me to know what's going on.
Yeah, I two things, and then there's one more question which we've kind of answered, but maybe we'll have Andrew reiterate his answer. But first of all, you know, Zach brought up a very good point, and that is that any monopolar energy near the balloon is going to ruin the hypertonic saline solution in there. And so you cannot leave the balloon, whether it's deflated or inflated, in the esophagus or stomach while you're using any energy near it other than bipolar energy. Bipolar energy will not affect it, but anything other than bipolar energy, whether it be ultrasonic or monopolar, is going to affect the balloon. So some people have asked, well, can I use, you know, my hook monopolar energy while I'm doing my myotomy, when I'm doing a laparoscopic Heller and leaving the balloon inflated? You cannot do that. It's going to affect the balloon in a negative way. So you have to pull the balloon out of the esophagus if you're using any energy other than bipolar. Number two, how do you bill for EndoFlip or impedance planimetry? Do you bill for it? And if you do, how do you bill for it?
Yeah, I bill as what I put in my operative report is you know, placement of the catheter, but then interpretation of the reading, and um you know, it's not a huge amount, but we've been getting reimbursed for the doing a read of the values.
Yes, yeah, I would just code 91040. Yeah.
Hmm.
And yep.
I think when you bill for it, you do have to have documentation though
Yeah.
of the of at least some of the numbers or
Oh,
whatever
yeah.
you have. I've been told by our billers that if I just bill for it without any documentation, and even if I document the note that I used it, if I don't have the actual, you know, distensibility index or
Yeah.
the DMIN or a cross-sectional area, you don't get reimbursed. So you do get reimbursed. 91040 is a CPT code, but you do have to document your findings. And then Andrew, could you just reiterate, there's a question again about what you would do if the DI was still low. I thought you had a great answer on that. You know, post myotomy and poem. Can you just reiterate your answer one more time?
Yeah. So I go back into the tunnel, and then you know, when I've made my initial myotomy, like I said, I usually go about 1.5 centimeters or 2 beyond what I think the GE junction is, just based on my subjective measurements. And then I try and just have done circular muscle fibers. And so my two moves, if it's still low, is to go longer with the myotomy, and or go full thickness in that segment where the GE junction is, which is probably like a, I don't know, I probably do it over like a 3 centimeter segment there onto the stomach and go full thickness. And I think for me, what's gotten me the most release is not necessarily extending it longer, but extending it, doing that full thickness piece. I feel like that's gotten me over the hump on those ones where it's just not quite there.
You guys are awesome. Really great talks. Your experience is valuable for all of us. So we appreciate you sharing and spending time out of the hospital teaching all of us about poems and EndoFlip. So thank you guys very much. We appreciate all of you that attended. Again, this is CME. You will get a email from the American Foregut Society, who we thank for supporting this, along with Endoscopy Now. Jordan, we appreciate, and Jim, all of the time that you spent helping put together and produce a great webinar. So thank everybody, and we hope to see everyone in the future. If you haven't joined AFS, do so now. It's a great meeting. Education is a priority, and what we care about is the foregut. So please join. Thank you, everyone.